Good morning. I'm Dr. Adithya and I'm a consultant in the Department of Critical Care Medicine at Yashoda Hospitals, Malakpet. At the outset, I would like to thank ISCCM Hyderabad for providing me with this opportunity of speaking on this platform. I'll be speaking on evaluation of a delirious patient, non-pharmacological intervention, and prevention of delirium, with special emphasis on the role of ICU nurse in prevention of delirium. Now, delirium is a sudden and fluctuating disturbance in the mental function, which is usually reversible, and it is characterized by inability to pay attention. It is characterized by disorientation, inability to think clearly, and there are fluctuations in the level of alertness of the patient. Now, why are we talking about delirium? Delirium is very commonly overlooked, even though it is a very commonly occurring entity in our ICUs. It is commonly overlooked with a prevalence of almost 16 to 60%. This is based on an Indian study. They have said that the prevalence of delirium is anywhere between 16 to 60%, which is quite significant. It is associated with increased morbidity and mortality of the patient. So a delirious patient will stay in the hospital, stay in the ICU for more number of days with added burden, some fresh problems coming up, fresh issues coming up, which will ultimately lead to increased length of ICU stay. Now, what are the consequences of delirium? Now, if the patient is intubated, so intubated patient, if the patient gets delirious and disoriented, there is always a chance of self-extubation. If the patient also can have event related to Foley's catheter removal or a central line removal, which happens pretty commonly these days, and it adds to the patient's morbidity, excessive complications, and then more duration of ICU stay. There is also a worsening of a sensory motor function following hospitalization. And when the patient gets discharged from the hospital, from the ICU, there is some deficit in the sensory motor function. And also, delirium would lead to long-term cognitive impairment of the patient, which will affect the patient in many ways. Now, what are the risk factors of delirium? Now, when we have a patient with an advanced age, or we have a patient with a history of alcohol addiction or a very chronic illness, pre-existing dementia and physical immobilization, the patient bedbound for too long, and also if the disease burden of the patient is pretty high, the patient is depressed, patient is having severe sepsis or any metabolic changes like hyponatremia, hypernatremia, and various other metabolic disturbances, and presence of invasive devices like long-standing Foley's catheter or endotracheal tube. So these are all the risk factors for the patient to go into delirium. So if we have a patient with all these scenarios or all these factors, then one must always assume that this is the patient who may go into delirium, who may land up into delirium, and then we have to be prepared for that. Now comes the question, why does delirium happen? Well, nobody exactly knows as to why it happens or what is the exact cause, but there's some theories. So it can occur due to some abnormalities in brain metabolism and neurotransmitter release. Specifically being specifically we can say that there is excessive dopamine or deficiency of acetylcholine that occurs, and this leads to delirium. Now, when we come to classification of delirium, there are basically three types of delirium that one must be aware of. There is hyperactive delirium, in which the patient is agitated or has hallucinations or disoriented, very disruptive behavior. They're like self-destructive type of a people. They just try to jump out of the bed, pull out the lines, or this. Very commonly, we see that the patient tend to behave very erratically, and they always have the demand of they want to walk out of the ICU. So these are all patients with having hyperactive delirium. Hypoactive delirious patients are usually lethargic, confused. They are very dull. They are confined to the bed, and then they have poor attention span. So this is the type which is very dangerous. Hypoactive delirium is the most common type that occurs, and it is pretty severe type, and it is usually overlooked. When we have a hypoactive patient, we are all happy, okay, fine, the patient is minding his or her own business, and then they must be okay. That is the usual assumption, but no, hypoactive delirium is a silent killer, if I would like to put it in simple words. So we have to be very wary of this situation, and then appropriate interventions must be done. Now there is another type of delirium called mixed delirium, wherein we find features of hyperactive delirium and hypoactive delirium in a phased manner. So when we have a patient with agitation at one point of time and then again lethargy at another point of time, then we can say that the patient is having mixed delirium. Okay. Now, when we attempt to assess the degree of delirium, there are many scales. There are many methods wherein we can assess and screen the delirium. The most common being the confusion assessment method of ICU. Then we have the NISHAM scale, then a nursing delirium screening scale, delirium detection score, and intensive care delirium screening checklist. So let us consider this one by one. Confusion assessment method is looks pretty simple. So basically it considers four parameters. So first parameter that is considered is acute change or a fluctuating course of mental status. If the patient has it, then we go to the next step. Look for inattention. Then if there is inattention, then we assess the level of consciousness. So the level of consciousness is assessed by RAS, that is Richmond Agitation Sedation Scale. So here there is a spectrum. Uh, the patient is alert and calm, then the score is 0. And then depending upon whether the patient is agitated or the degree of hypoactivity, there is scoring that is given on either side of the spectrum. If the RAS is other than 0, I mean if the score is something other than 0, then the patient is said to have delirium. If the RAS is 0, then we go into the fourth parameter, that is we look for disorganized thinking, whether the patient has any disorganized thinking or not. So if there is disorganized thinking, then the patient is said to have delirium. So these are the four parameters that are considered. NISAM scale looks pretty complicated. It's not easy to use. It's said to be a screening tool, but it's not easy to use. As we can see, there are 9 parameters, and then in each parameter there are like scoring from 0 to 5. And this table looks a little bit busy, and it's kind of complex. So, and also there is another drawback to this table, that it can only assess those who could express verbally. So if we have a patient who is intubated, then no, we cannot use this scale. So the scoring system is between 0 to 30. So lower the score, more the degree of delirium and confusion. Now we also have this nursing delirium screening scale. It employs a scoring from 0 to 0, 1, 2, and there are 5 parameters that are used. This is also a screening scale, but not that commonly used. Again, we have this intensive care delirium screening checklist. This is one of the parameters that people have used to screen for delirium. Again, we can see a total of 8 parameters that they have used, and then there are scoring systems for each parameter. Now, when we consider all these tools for assessment, what studies have found that is the first thing, the confusion assessment method for ICU has it has a better reliability when it comes to diagnosis and screening for delirium. So it is simple, and then we can use it on a day-to-day basis, because it has just 4 steps that we need to consider. Now coming to the role of ICU nurse in delirium prevention, well, when a patient lands up in the ICU, the nurse, whoever is attending to the patient, is no closely bonded to the patient. The patient has that nurse who is somewhat close to his or her family, because the patient's family is outside the ICU, and basically the patient has nobody else to talk to. So the nurse is someone the patient can communicate, can bond. So the role of the ICU nurse is very important when it comes to prevention of delirium for the patient. Now let us consider a typical ICU scenario. These are the sounds that one experiences. Okay, so this is the environment that the patient faces. You can see a closed environment without any windows, nobody to talk to. Okay, and then the only scene that the patient sees is a rows of beds, machinery, equipment, and it's a very strange environment the patient goes through. And definitely the patient does not feel at home, and the patient is distressed. So this is the environment the patient is put into when the patient gets admitted to the ICU. So very distressful environment. We as healthcare professionals, healthcare providers, we have shifts of hardly 8 hours or 9 hours in the ICU, and we come out of the ICU and then we kind of get recharged mentally. But please imagine how the patient would feel. So it is definitely very distressing. So when it comes to prevention of delirium, there have been many studies, and then there have been many meta-analysis when it comes to analyzing what are the methods or what are the interventions that can be employed in prevention of delirium. Hence, there are some non-pharmacological interventions like regular orientation to time, date, person, and place. Like, as soon as any healthcare provider goes to the patient, we can, introduce ourselves and say that, hey, good morning or good afternoon, I'm so and so, and nice to meet you. And then today is this day, today is this time. I hope you are aware of it. So, kind of, getting the patient too close to reality, so you can make the patient aware of what time it is or what day it is, so that the patient stays in touch with reality. Next measure that what one can employ is reduction in the isolation. So if the patient is very isolated without any human contact, without any other person to talk to, then the patient has a tendency to go into disorientation and delirium, because there won't be any stimulus, visual or any indicator as to what time is it or what day it is. So this is one thing that can help in preventing delirium and ensuring visible daylight. Hence, you can see here that if we have a room or an ICU room with, decent sized windows, so that the daylight can come in, the patient can know what time it is or what time of the day it is, so that the patient can get adjusted accordingly. The circadian rhythm also can get adjusted accordingly. So, attempt to maintain the normal circadian rhythm is something that doesn't happen routinely in the ICU, because of all the noise that occurs in the ICU, the noise from the machinery, the noise from people walking in, people walking out, some or the other activity keeps going on, and the medications that get administered at very odd hours, and definitely the patient being in the ICU would not feel comfortable sleeping, so the sleep cycle gets disturbed. So because of this disturbance in the sleep cycle, the patient gets delirious eventually. Hence, there have to be attempts to maintain the normal circadian rhythm, like at the night time switching off the lights, minimizing the doses of medicines to be given at a particular time, between midnight and 5 o'clock, so that the patient gets at least that amount of rest. So all these things can help in preventing the delirium. Also exposing the patient to some kind of watches or digital clocks, so that the patient can know what time it is. And also cognitive stimulation, that's also very important. Put making the patient solve some puzzles, or giving a newspaper or some kind of a reading material, music, audio visual aids, that we'll be discussing again later. So all these things can help us prevent delirium. Family support is really important. So we have seen during COVID time that in certain areas the family was not made to visit the patient, and then patient ultimately they got delirious. That's a usual thing that happens in the ICU. So the more the family gets to meet the patient, or the patient rather, the patient gets to meet the family, the patient will be mentally comfortable. Like, continuously when the family support keeps on getting delivered, the patient will be mentally comfortable, and hence that can result in prevention of delirium. So allowing the family, I mean, in the ICU definitely it may not be feasible because we have limited visiting hours or so. But if we have a patient wherein we know that there is a risk of the patient going into delirium, then we can try to adjust the visiting hours and then let the family be with the patient for a little bit longer time. If the patient is isolated, yes, we can employ this kind of a method, providing some facility of video calls. And yes, during COVID time also, we have seen that everyone is in PPE. The patient, anybody would get terrified seeing someone in this attire. So sometimes this kind of arrangement, like putting in a photograph on the PPE, can help in can help the patient in recognizing the healthcare provider, and hence increase the level of comfort. Music therapy is something that some many centers are doing. It definitely helps in you know aiding the recovery in certain aspects, the mental recovery, I would like to put it that way. So music therapy kind of stimulates the brain, certain areas of the brain, and kind of keeps the brain occupied. So that is one thing that we can do. Now, minimizing the restraints. So this is ironic. So when we have a delirious patient trying to pull out catheters, trying to jump out of the bed, the most common thing what we do is restrain the patient. Now, studies have shown that restraining the patient will increase the amount of delirium. So this is kind of a very fine balance that we need to have between restraining the patient indefinitely and trying to prevent delirium. So yes, if the patient is very combative, we have no other choice but to restrain the patient, but at the same time maybe a little bit of a support, emotional support, if we can provide the patient through family or through healthcare, whoever is through the bedside nurse, and then we remove the restraint and then try to communicate with the patient. So these are the things that can decrease the amount of delirium. Also, other measures like providing good hydration to the patient, and then providing certain visual aids. If the patient is visually impaired and the patient doesn't have glasses, so lack of proper visual what do you call stimulation also can lead to delirium. So providing appropriate aids can lead to prevention of delirium. Yes, early mobilization can help in prevention of delirium. The earlier the patient is mobilized, the more stimulated the patient's brain becomes, and then ultimately it can help in a faster discharge from the ICU, and ultimately it can lead to reduced costs that the patient bears. Now, what are the challenges in prevention of delirium? So, in the current scenario, I would say that the ICU is intensively chaotic unit, because this is a tropical fever season. Any season, whatever it is, the ICUs are usually very chaotic. So, doing all these measures what we have discussed earlier may not be feasible. And also we have the nurse to patient ratio, we don't know, 1 is to, I don't know how many patients depending upon the load. Sometimes it is 1 is to 2, 1 is to 3. So delivering care, appropriate care to all the patients is a herculean task for the ICU nurse. At the same time, doing this non-pharmacological measures, it's humanly not that feasible, I would say, in a chaotic situation in a high intensity ICU. So that's why when we have predominantly sick patients, it's many things keep going on, many consultants come in, many orders that have to be followed. So the care of the patient, the emotional support or the non-pharmacological interventions, they kind of take a sidetrack when it comes to managing these patients. Now, what's the way forward that we can do to prevent delirium? What we can do is we can have a dedicated staff who takes care of all the non-pharmacological interventions in prevention of delirium. Family involvement we have already spoken about earlier, taking the help of the family, of the family in orienting the patient and then keeping the patient sane a little bit closer to home. Audiovisual aids we have already spoken about, providing music therapy, newspapers or visual aids. And then improvisation, yes, the bedside nurse can always be creative in finding out new ways in order to recognize and prevent delirium. So ultimately, what I would like to point out is that the nursing staff who are taking care of the particular patient at risk of delirium are definitely in a position to assess the patient's risk, identify how many episodes of delirium the patient has, and initiate non-pharmacological measures for preventing delirium. And they can also educate their peers and their colleagues about the risk of delirium and ways of managing delirium, as well as they can involve the families of the patients in reducing the risks of delirium.